I'd first say let's go back to the guidelines. Both the STEMI and NSTEMI guidelines from the American Heart Association, American College of Cardiology, recommend at least 12 months of therapy with dual antiplatelet therapy, meaning both aspirin and a P2Y12 inhibitor, for 12 months. And then in certain patient populations, you can extend that beyond it. The difficult thing is that's been the trouble lately. There's been an enormous amount of literature that's come out in the last 2 years, actually, and a lot of it within the last 12 months, that have looked at, like the DAPT trial, which has looked at extending therapy out to almost 3 years. There's also multiple trials in the space of looking at 3 months of therapy versus 12 months, things like the RESET trial. And then there's other trials that have looked at, like the security trial, that have looked at 6 months versus 12 months. Interestingly enough, there's some of these trials have been able to show benefit with doing any of these. And a lot of it has come down to the fact of, were they powered efficiently? Were they looking at the right patient populations? So I would say at this point in time, the best thing to do is to follow the guidelines, in the sense that all patients should receive ideally a minimum of 12 months of therapy, provided they don't have a bleeding event or something else during it. Since we do have data that shows that we can treat for a shorter period of time, if a patient does have something like a GI bleed or a complication, you can shorten therapy, at least according to the European Society of Cardiology guidelines, down to potentially 3 to 6 months of therapy. Would not recommend that ideally in everyone. And then as a marker of who to continue therapy out in, the consideration should be given to the fact of, like the DAPT trial, these patients did not have an event within the first 12 months. So what that means is they did not have another vascular event, nor did they have any complications from the therapy. And then those patients were continued on afterwards and had some improved outcomes. But anytime we extend treatment, we also extend the risk of bleeding. So careful consideration should be given to those patients. Often patients that may have had multiple MIs, maybe patients with a history of diabetes and things like that, but this is none of this is very clear-cut yet, so we're still waiting for the perfect trial that's going to give us the answer in all situations.